There you go. So that's it?
I think that's it. I'm gonna, is it actually started?
Well, it is recorded.
Okay, so we're gonna pause. We'll see if anyone signs in. This is like the.
Otherwise, we can just record ourselves,
Yeah.
see what happens.
One option, if nobody's on there by 10 after, we'll just call it a day.
Peace out.
I gotta turn my sound off. Very signed on. Yay.
Oh, I should have printed full slides because, like, I can even read these with readers.
No, I'm sorry.
No, this is ones I brought.
Oh,
So while we're going through here, we're going to see the slide deck on one side. Up there.
mm-hmm. So yeah, well, I can practice. Good.
4 minutes till showtime. Panic!
It's good for me to practice. See, Lucia does this usually.
Mm-hmm.
One participant can share at a time. This little thing here.
You can just feel
I wonder
the
if you just hit the share, the little green thing. So, yep. And yep,
Yeah,
secret location.
here we go.
And then you could
Then
enable.
you'll see us on the side.
So do the hit slideshow, and I think you're gonna have to enable it, right? There you go. Would you be? I mean, for me, it would be awesome if you could just flip it.
You would prefer?
Yeah, I'll just let you know. Is that okay with you? Because otherwise, I might shut it off,
Yeah.
which would be sad.
I'm happy to do that.
Okay.
That's the one that doesn't. This is the one with the slides. This is the one where I can keep track of things.
Oh my gosh, so many pieces of technology.
Remember when this was like overhead acetate overlays?
Yes, we still use those at some of my stuff.
Hmm.
Yeah.
Somebody's out there. Drugs are bad, okay? You know how hard it is to work Towley and South Park references into presentations?
Don't do that.
Too late.
My husband was trying to get me to like South Park last night, and I just
Last night.
He was, I know. Well, he was trying to convert me again. He keeps thinking it's so funny.
Sarah Drake, who used to run our pharmacy unit at DHS, pharmacist, doctorate degree in pharmacology, right? In her office, she had this little Towley character.
Oh, she had one of the offices with a fake wall.
With fake walls.
Yeah.
Approximately as thick as a piece of sheetrock.
Yeah.
So just to let everyone know, we're going to let a few more people sign on, and then we'll get started. Thanks for unmuting or muting yourself, and we will have people do introductions in a few minutes.
You could have them chat and see if they can hear you. Just, you could say, type in the chat and see if you can hear. Yep.
Can you hear me now? Does too much self-love make you jealous of people who envy you?
They can hear you too, Rich.
Yeah.
No cussing.
Everything
Stop.
So when we start, will you close the door? I want to leave it open as long as I can in case we're thinking.
And with that, I'll pass. Like a newscast.
I know it does. Feel like, do you want us to start? What do you think?
Okay, how about that opioid problem? Over to you.
All right, we're going to go ahead and get started. There may be some more people joining us as we kind of move through the hour. My name's Rebecca Buller, and I'm here to welcome you to the Wayside Women's Services Echo. Thanks for joining us. You're going to see me on two screens because I'm running technology as well as being your host today. Couple of updates and reminders. We will go through and introduce ourselves, but unless you want to be speaking to the crowd, keep your mics on mute, and that's helpful. You have so far. And then I think what we'll do is we'll do introductions, we'll have the presentation, and then time for questions. And then finally, I'll have a few kind of closing remarks with updates and things to look forward to. And if for any reason someone is in a room with several participants, will you please sign in through the chat room so that I make sure that I get your attendance and that I can respond to you with an email with our survey, our evaluation survey, the handouts, the PowerPoints, and also whether you would like continuing education credit. So make sure you sign in as well as let us see you. We have a lot of people who aren't sharing their faces, but that's okay. I get it. I'm not comfortable doing it either. So let's start with Mary. Mary, I'm gonna unmute you and ask you to go ahead and introduce yourself.
Oh, great. My name is Mary Biltzo, and I'm currently working at North Star Regional Treatment Center in Chaska as a peer recovery specialist and a tech.
Wonderful. Thank you for joining us.
Yeah, thank you.
And now let's go to, is it Hofield in Meeker County? Is it Jean? I can't quite see who it is. Can you introduce yourself? Last name Hofield? You want to go ahead and introduce yourself? Okay, I'm going to unmute you. No. Okay, talk. You've got it. All right. Well, why don't we come back? You play with that, and I'm going to mute you again. Tiffany, I'm sorry, looking down at my sheet. Tiffany, will you please introduce yourself?
My name is Tiffany Morgan. I'm the Chemical Health Program Coordinator for Proof Alliance.
Tiffany, we can hardly hear you. Can you get a little closer to your microphone?
My name is Tiffany Morgan. I'm the Chemical Health Coordinator for Proof Alliance.
Wonderful. Thank you for joining us. Let's go back here. Jean, in Meeker County or Hofield? I can hear you.
There's no audio.
Okay, no audio. That's fine. Welcome, and we're so glad you're here. And this person is a 218 area code, and I can't tell who you are. Do you want to let us know who you are?
Can you hear me?
Yes, I can.
Okay, my name is Sherry Willette, and I'm from the Tagwee Recovery Program in Cloquet, Minnesota. I just can't seem to get online, though, but I can hear you.
You can hear us. That's great. We'll start with that, and so glad you could join us.
Yes, thank you. I'm excited.
Good, good. All right, so we're gonna go ahead and turn things over to our presenters who will introduce themselves and give us all the wisdom that they can at this point. Let's do that. Go ahead.
The other 58 minutes.
You want me to start? Hello, everyone. I'm Catherine Wright, and I am in charge of early childhood mental health at the state of Minnesota. I've been there for about 10 years, and my job is to create or to develop and manage the early childhood mental health system. I'm also a licensed psychologist and a licensed clinical counselor. I've been practicing for about 25 years, and I actually still practice very part-time, 1 day a week, doing clinical work, which is really lovely because I think it's important if you're developing policy that you actually practice in it, so that you make sure that the policies are working well. So it's a little bit about me.
Oh, thank you. I'm Rick Moldenhauer. I'm with the Behavioral Health Division, Minnesota Department of Human Services. I am a Health Human Services Rep 2 is the title, and I'm also the representative for the State Opioid Treatment Authority for the state of Minnesota. I've been here since May of 2001. I perform and have a variety of tasks that I do, primarily as technical assistance around a variety of delivery of substance use disorder treatment services.
And we would just go ahead and begin.
And get started. So a little bit of background is this presentation is based on an article that Rick, myself, and a colleague of ours, a couple colleagues, Ruthie Dallas, and then a researcher developed, a researcher by the name of Elizabeth Carlson, who's at the University of Minnesota, developed. We wrote this article for a journal called 0 to 3, which focuses on development and mental health issues related to infants and toddlers. And so that's what our presentation is about. And eventually, I think we'll be able to get you the link so you can actually download the actual article. So we're in the process of getting the slideshow up for you.
Sorry, just a second. It was here a minute ago.
So you are sharing
I
it.
am sharing.
Yep. So all you need to do is enable edit and then return to slide so that it'll start to yep.
Sorry, yellow. Yellow. Yep. Thank you.
We did. We did introductions. She's getting ready to start this slide.
Screen sharing has stopped at the share.
So you can share again. Yep. Yeah. So you could just, through the chat, ask if they can see it. Oh.
Somebody's phone just shut down. Let's see.
While you're doing that, would you like Ruthie to introduce herself?
Yes.
Go ahead, Ruthie. Introduce yourself. We just introduced ourselves.
Hello, this is Ruthie Dallas. I'm with the Minnesota Department of Human Services in the Behavioral Health Division and serve as the Women's Services Lead in the division and also as the Women's Services Coordinator for SAMHSA NASDAQ.
All right, so let's try this again. We've got it enabled. We're going to show the slideshow from the beginning.
Awesome.
There we go.
Awesome.
And they can see it.
Awesome. So if you could forward to the next slide. Great. So I will start. I should also say, this is Catherine again, that most of my clinical work over the past actually 25 to 30 years has been working with young children and families. And just a little bit about early childhood mental health. Everything we do with young children is done in conjunction with their parents. We don't ever see young children alone. that's not evidence-based or helpful. So we like to see young children with their parents. So thinking about that, part of what we always like to talk about is using a developmental lens when we're thinking about treating young children and supporting their development. And what we know from the literature and research is that for healthy development for young children, I'm talking birth to 6, what's really required is consistent, responsive, and sensitive care. And that generally is provided by a parent or a caregiver. So what we know for infants is that what infants need to develop in a healthy way is they need parents to comfort them when they're stressed. They need their parents to support their exploration of their environment without intrusion. So that's basically how our little ones learn how to crawl, how to explore their environment. If you have parents in there that are trying to take over or don't allow them to explore, children don't get some of those skills. And then the final one that that is shown by research is that parents need to delight in their children. And what that means is they're giving them positive reassurance, often through smiling at their children, praising them when they do a good job, or even praising them for trying. So that's what infants need for healthy development. For preschoolers, they need all of that, and they need their parents to give clear directions. And what I mean by that, and I should say I'm also a parent, oftentimes when we see our little ones doing something that's not so helpful, such as like running, and we want them to walk, oftentimes parents say, don't run. Well, I will tell you honestly, what a preschooler hears when a parent says don't run is they hear run. So instead, we like parents to give a direction of use your walking feet. So telling them positively what to do and being very clear about direction. So instead of saying, be safe, little kids don't know what that means. What we want parents to often say, which is much more clear, is hold my hand while we cross the street, or put your bottom in the chair as opposed to standing on the chair, or keep your hands in your pockets if you're in a store, so kids aren't touching stuff. So that's what we mean by giving clear directions. The next thing that preschoolers need is they need limits and discipline for safety and noncompliance. Part of what that does for young children is it helps to keep them what we call regulated and learn how to calm themselves down. Little kids cannot do that by themselves. They need parents to give them guidance on that. And when I say set limits, it's being clear about kind of what the limits are for kids. So I always think about my son when he was little. And one of the rules we did have, we live in North Minneapolis, is that he had to hold my hand when we crossed the street. It wasn't an option. It was always very clear. I would never allow him to cross the street by himself because he'd get hit by a car. And so we would often have that conversation, even if he said, I don't want to. It doesn't matter. Your choice is you're either going to hold my hand on your own or I'm going to help you. So those are the things around setting limits. And then the final one is really demonstrating some confidence in their parenting skills. And what I mean by that is that when parents waver, especially with young children, so they don't quite know, so they might say, okay, I want you to hold my hand when we cross the street, but then they are worried that they're not going to follow through on that, so they say maybe not. What children need is their parents to be confident and be consistent. And so those are some of the basic skills. Okay. A couple of things that we know that parents who are struggling with chemical dependency issues might struggle with those infant cues of being sensitive and consistent. And this is based on research again. And what that means is that sometimes parents who have both chemical dependency and mental health issues don't necessarily read their children's cues very well. So if you have a crying baby, what we've been finding through the research and actually in my own practice, working with families, is that sometimes not understanding that when a baby cries, it really has nothing to do with the parent. It might just mean that baby just needs to be picked up. And if parents are feeling like like the baby's mad at them, babies don't necessarily have that ability to have that kind of intention. They might not pick them up. So being able to read a child's cues is very important, and that sometimes doesn't happen when there's chemical dependency involved. And that's particular for mothers. I will say that unfortunately in the literature, the majority of the literature is on mothers, and there's very little research on the impact of substance use disorders on fathers. And I think that's the next area of research that all of us need to really be thinking about.
Okay. As part of our presentation today, I'm going to give a kind of a snapshot overview of what opioid use disorder looks like in Minnesota. And then from that, dovetail it down a little bit to individual and familial system impact. If you look in the current iteration of the DSM, 5th edition, you'll find that there are 10 categories of substances of use. The one that we're here talking about primarily today is opioid use disorder. So when we're talking about opioid use disorder, you're talking about a blend of illicit and sourced, at least licit, pharmaceutical substances. So as a category or a classification, we're talking about prescription pharmaceuticals, Schedule 2, Schedule 3, and so forth, as well as heroin. One of the points that I want to make about this is historically there's been a view of substance use disorder as an individual affliction or as an individual disease or however, whatever your philosophy is of that. While that is still predominant in a lot of circles, if you see or believe that a substance use disorder is an individual condition, that's up to you, but it in my mind undeniably has a familial impact. No one is an individual when it comes to family systems. So what impacts one is going to have systemic effect throughout the entire system, both immediately within the constellation as well as other affected individuals. There is no specific demographic for opioid use disorder. You're going to find opioid use disorder everywhere in every demographic. Male, female, every way you want to slice demographics. It has a larger incidence when we measure by population in certain areas, demographics, geographic, what have you, but no one is immune to this. So it's not a matter of moral flexibility or something to that effect. There has been a lot of talk about pharmaceutical opioids as a primary substance of abuse now for a number of years. Dane's data, the tracking mechanism we use in treatment programs, tells us that beginning about 3 years ago, pharmaceutical opioids as a primary substance at time of admission was equaled and surpassed by heroin. So right now in Minnesota today, heroin is more prevalent as a primary substance for treatment admission than pharmaceutical opioids are. In fact, it has become a tertiary substance at this point, secondary only to alcohol as within the general population and methamphetamine. If you look at the map you hopefully see on the right-hand side of this slide, that is for calendar year 2018. That is for heroin as a primary substance at the time of admission. What you see there are by county of residence, not by county of treatment provision. So this is the county where someone claims residency at time of admission, controlled for an incidence per 1,000 to set an equal play field, so to speak. So in other words, it takes into account greater population densities in the 7-county metro area rather than outlying metro area. Basic rule of thumb, the darker the color that you see up there, the more people who reside in that county at time of admission whose primary substance is heroin. What stands out to you about this is a couple of things. One is that there are more people seeking treatment admission controlled for by population in greater Minnesota than there is specifically in the 7-county metro area. That runs contrary to a lot of what you might call garage logic. You'll also notice with this slide with heroin, and then there are other slides available I can send to you if you'd like them, where it's the same type of process, only it uses methamphetamine or other substances. You're going to notice that with heroin here and with pharmaceutical opioids and methamphetamine for that matter, that the greatest concentration for individuals seeking treatment admission is in counties that are either on or physically contiguous to reservation boundary, as you'll see on the map here. The county in Minnesota that has the greatest concentration controlled for in population is Monoman County at this point, based on treatment admission data from 2018. Next slide, please. There's a couple of things that are similar to other substances, but then have some degree of uniqueness, if you would, for opioid use disorder. There is what is termed or deemed in literature.
That's okay. She canceled it already. Oh, she did? Yeah. Dan knows about it.
As a natural course of progression of the illness. Opioids without getting too deep into the chemistry and pharmacology of this, opioids have an effect of hijacking an endogenous built-in biochemical system that all of us happen to have. Most people have heard of endorphins, which is a natural painkiller. Opioids, pharmaceutical or heroin, what have you, take advantage of that built-in neurochemical pathway. So what you will see as a general rule of thumb is a swifter, greater progression through physical dependency and then move into symptomologic clusters indicative of pathological use, or in other words, a use disorder. The diagnosis for opioid use disorder, whether it's intoxication and withdrawal or an OUD, mild, moderate, or severe, looks a lot like other conditions. So you can have the same client, the same patient come into the same door, and whether your background is in substance abuse or mental health or medicine, we all come to the table with our own backgrounds and trainings. So we will see the same person in different ways. A common situation that comes along with this are people who are intermittently in opioid intoxication and then as a product of that go into opioid withdrawal. If you look at that person coming from a substance use disorder background, you will see symptom clusters indicative of opioid withdrawal. If you come to that from a mental health standpoint, you're going to see a lot of generalized anxiety disorder. The symptom clusters in the DSM-5 for opioid withdrawal and for generalized anxiety disorder are nearly synonymous to each other. There's only a couple of fairly fine gradations between the two. So unless you have the opportunity of a lot of time and the ability to do a lot of in-depth analysis as you're looking at clients as they come in through the door, you may miss some of those fine symptomologic details. There's a reason why a lot of people coming into substance use disorder treatment now may have a primary diagnosis of opioid use disorder, but then have a secondary diagnosis of generalized anxiety disorder and are then on anxiolytic medications as a function of that. And so you get into a lot of synergistic problems with people who are using opioids that are then using an anxiolytic or an anti-anxiety medication. Many of those are benzodiazepine-based. The two can work together to suppress your ability to ventilate. And if you stop breathing, there's little opportunity for treatment intervention past that point. Another driver right now, nationally and in Minnesota as well, is the quantity, the potency, and frankly, the cheapness or the availability of opioids, specifically with heroin. The people I work with in law enforcement will tell me that a basic dose use, or a balloon, if you would, is a common street term for it, is about $10 right now. If we look at what is going on in Minnesota today compared to even 10 years ago, the BCA, Bureau of Criminal Apprehension's lab analysis would tell you 10 to 15 years ago, the average heroin sample in Minnesota was maybe 20 or 30% pure heroin with other binders and cutting agents. In today's world, it's about 80% pure heroin. And now, as you've seen in the news, there's a lot of concern about other opioid analogs like fentanyl and carfentanil being used as cutting agents, which then increase the potency and increase the opportunity for iatrogenic or unintentional overdose. When we look at treatment admission data, one of our largest bubbles right now for opioid use disorder is an emerging group of 20 to 24-year-olds. So you have a lot of people who are coming into the system, coming into treatment now with their first treatment experience, who do not have a lot of the life experiences that a 30 or 40-year-old individual has, who have learned how to modulate their withdrawal symptoms and basically take care of themselves coming down, which again adds to a lot of that unintentional overdose. Younger people devoid of life experiences of how to take care of themselves, frankly, and unintentional overdose is a product of that. On the right-hand side of your slide, the slide you see here is, again, just my attempt to drive home to the point that little children through adolescence and early adulthood are little sponges. What they see is what they learn. What they see is what they mimic. And so the environment that children grow up in and what they see and what their experiences are is often what they learn and then what they emulate. So even though a parent may have an opioid use disorder, it's going to have a family systemic impact just by virtue of what the child sees and what the child experiences. Actively, abuse; passively, simply neglect, or what the child grows up seeing. What the child grows up seeing is what the child then begins to believe or learn of what is acceptable or normal behavior. And then as they progress forward into adulthood, they will continue to emulate that. Moving along.
All right. So now we'll talk a little bit about what happens with opioid use during pregnancy. So a couple things that we know from, again, the research is that when a pregnant woman is using drugs or alcohol during her pregnancy, it's associated with premature birth, low birth weight, slowed growth, and there could potentially be long-term physical, emotional, behavioral, and cognitive problems in that child. Especially with alcohol in particular, it has very lasting effects that are really hard to change. Particularly with opioids, what we've been finding across the nation is that if the mother is actively using, the fetus might develop a tolerance to the opioid and be born with what we call neonatal abstinence syndrome. And so basically what's happening is that when they are delivered, their intake of the opioid is cut, and then they have withdrawal symptoms. And sometimes those withdrawal symptoms, especially for a newborn, can lead to death because they're so very impacting. So part of what we think a lot about is, and I should also say, so we're paying attention prenatally what's happening. I think we don't have quite enough literature yet to know what the long-term effects of opioid use are on a developing child after they are no longer exposed to it. We learned a lot, I think, from crack cocaine, and that initially the children were very dysregulated. Their central nervous systems were dysregulated, but they were able to, with sensitive caregiving, be able to develop some skills kind of on a normal trajectory. I'm not sure what we've learned yet about opioid long-term use. Alcohol, hard to reverse. So just something to keep in mind. The other thing that we often like to pay attention to, as I was saying earlier, if the parent is using after the child is born, it absolutely will impact their ability to parent, which we know. And thus they can't give that sensitive caregiving that child needs for healthy development. So even if the child was doing okay if they were prenatally exposed, but they didn't develop neonatal abstinence syndrome, they were developmentally okay. If the parent is still using it, absolutely can compromise that child's development, because we know that children develop in relationships. Development is not outside of relationships. Hopefully that makes sense.
Okay. Just echoing what Catherine said, while baby is fetus, while baby is still on board, baby does not have a choice as to whether or not baby is going to be exposed to the parent compound of an opioid or a metabolite. There's a variety of opioids available. We can talk about mu opioid receptor, kappa opioid receptors, and so forth. And some of those do cross placental barrier, some do not. Some will have a direct impact on fetal development. Some will have a secondary impact on fetal development by the effect it has on mom. A more passive method would be not going in for OB-GYN checks, poor nutrition, prenatal care, things such as that. So at the point of delivery, when clamp, and cut, once the umbilical cord is cut, the fetus, the baby's access to the opioid is then terminated, it's cut. So baby will then, if it has developed physical tolerance to the opioid, start to go into withdrawal. Opioid withdrawal in a newborn looks a lot like colic. And so what you have is a symptom cluster in a newborn that's going to look like anxiety would in an adult. And because there's not necessarily a sensitivity on the part in the delivery room of opioid exposure, what they're going to see is a screaming, crying, colicky child that will then move forward, and they will look at it as a care from that standpoint rather than dealing with it as neonatal abstinence withdrawal syndrome, unless they're aware of it at that point. A little bit about medication-assisted therapy. MAT, medication-assisted therapy, has been around for a while. It's become better known and more popular in the sense of more prevalence as a function of the increase in opioid use disorder. Federally, you're going to find 3 medications that are FDA approved for the maintenance or withdrawal of opioids. Methadone, which has been around for a long, long time. Buprenorphine products under the trade names of Suboxone and Subutex and a few other formulations. And then Vivitrol, things along those lines. The two most common ones that you'll see nationally, certainly in Minnesota, are methadone and buprenorphine. In Minnesota, we have 17 opioid treatment programs scattered throughout the state. Most of them are concentrated within the 7-county metro area. 2 are residential, the rest of them are all outpatient, and we have at any given time about 6,800 people dosing out of those clinics on any given day. Average methadone dose is about 120 milligrams or so per day. We also have close to 500 now data waivered practitioners that can use buprenorphine in either a hospital-based residential or outpatient setting. I'm not going to get into all the various regulations. The point here simply is that there is a number of medications available and a process by which those medications can be used. A couple of urban myths about these medications. They are fundable through the Consolidated Chemical Dependency Treatment Fund. They are on the state formulary. There are methods by which people can gain access either to opioid treatment programs or to buprenorphine data waivered physicians. If you have any questions about how to locate those lists, feel free to get a hold of me, send me an email. I'll be more than happy to send you lists that go out to them.
Part of what we've also found, or the researchers have found, is that pregnant women who have some opioid use disorder issues might also have mental health issues. And what the literature has shown is that if they are not treated together, those women might drop out of treatment. And I will just say a little bit, when I was doing my dissertation for my doctorate in psychology, I actually was looking at mothers with serious mental health issues, but found that when they had a dual diagnosis of both mental health and chemical dependency, their ACE scores, if you're familiar with ACEs, one's childhood trauma, if they were duly diagnosed, their ACE scores were 9s and 10s pretty consistently, which was different than parents that had only mental health issues. And so again, thinking about chemical dependency treatment that needs to really be integrated with mental health treatment for these particular women is critical to think about, so that they, 1, will stay in treatment, but 2, so that they'll be better supported to parent their child. And then Ruthie, you didn't know this, but this last bullet is yours.
Okay, thanks a lot. Peer support specialists. We know this is a popular role and position in a number of substance abuse programs now, especially ones that we fund. We grant funds from SAMHSA to programs to serve pregnant and parenting women. And one of the recent roles and specialty roles that we have been dealing with lately are peer support specialists. We used to call them recovery coaches, but now we're using the term peer support specialists because Medicaid is now is available where programs can bill for these services. So we're excited about that. But we know this is a very important role because they provide a lot of the wraparound services and support services that women need in treatment and once they come out, especially when they're re-entering into the community and to the homes, back to their homes. And we're hoping that it can grow even more as far as getting this particular position certified, at least having individuals certified in this position. Recovery coaches were more on a volunteer basis for most of my grantee staff. And now we're moving toward making them billable and providing the services that are necessary out there. The training is very key that they have to go through as far as providing these services. We have the recovery community organizations that offer an ongoing training that you can become a peer support specialist. And I just want to say recently, we've even come up with a more specialized part for this role in dealing with maternal child health. And we had about 6 staff to go through this particular training recently and can provide the community health worker in combination with what the peer support specialist does. So we're looking forward to more around that as a specialized certification for this position. And we are hoping that the peer support specialists can be looked at as a career move for a number of the women and other families, members that are interested in entering to the field, but maybe not interested in going to the counselor level or administration level, but they can offer this as a part of giving back, but also helping that person in the recovery program. So it's a means of preventing that whole dropout aspect of keeping the individuals in there. But it's all about relationships that you heard earlier that Catherine had mentioned.
So there's not quite a lot, but there's some literature that shows that specific parenting interventions that are super helpful for parents who are struggling with chemical dependency issues. One of them, the top one here, Mothering from the Inside Out, is actually evidence-based, meaning that they've done enough trials with it to show that it has absolutely positive effects on parenting with mothers who have substance use disorder issues. That particular intervention, Mothering from the Inside Out, is not one that we have here in Minnesota. It's a 12-session individual psychotherapy done by a mental health professional, but it really helps support the parent, the mother in particular, in thinking about the cues of their child and what they mean, so they don't take it personally when the baby cries. And as Rick was saying, we know that babies who are prenatally exposed cry more than babies who are not prenatally exposed. So I'll just say they're hard to parent because it's hard to hold a baby when they won't stop crying. If any of you have had a baby with colic, it's very stressful. So similarly, and this intervention has shown to have positive impacts on the parent-child attachment relationship, which often is a marker for child development, positive child development. And it also has a positive impact on the parent's ability to read the child's cues. It is not in place of substance use disorder treatment. It is in conjunction with. It's an and, not an or. The next one I have listed here is called Fathers Too. And when I was reading about this, I was super, super excited because there's so little research on dads. And this is an intervention that was developed specifically for parents, for fathers in methadone programs. And again, it's individual psychotherapy, and it's paying attention to fathers' secondary substance use, their parenting goals, and their own ACE scores. Knowing that, as I was saying earlier with my dissertation, parents who have substance use disorders tend to have very high ACE scores that haven't been necessarily attended to. I should say, when I did my dissertation, I asked all 40 of the parents who I did those ACE questionnaires with how all of them were in mental health treatment. How many of you have actually talked with your ACE about your ACEs, not as ACEs, but just with anybody ever? And only less than 50% said that they had ever brought out their own childhood histories with a psychotherapist. And they were all in mental health treatment. So that just lets you know that we as a system don't ask adults what happened to them as children. So trauma has a lasting impact. And so this is what this particular intervention does, is it actually asks these dads about their trauma histories to address them and address their parenting. And then the final one I have here is that these folks, they're actually from the Netherlands, have done what we call a big meta-analysis. So they look at all of the literature across the world on parenting. And what they have found is, if we're going to really target parenting sensitivity or caregiver sensitivity, which, remember I told you in the beginning, is what absolutely matters for child development, the interventions that have the best effects, that are most successful, are behavioral in nature. So you're teaching parents what to do. They use videotape. So you're not talking about it, you're showing them and showing them their videotapes back. And they're short. They're 16 sessions or less. And one of the things I get excited about is we actually have an intervention that we use here across the state called Attachment Biobehavioral Catch-Up. I'm certified in that intervention. I actually just became a trainer of it. We train mental health professionals in it. It is 10 sessions. It uses videotape. It gives parents back their videotape information. And what the research has shown on, we call it ABC, Attachment Biobehavioral Catch-Up, is that children who have early adversity, and that includes being in child welfare and removed from their parents' home, or having prenatal exposure, or being involved or witness to domestic violence, their cortisol levels, which is your stress hormone, is off whack when they start. And after 10 weeks, it gets a normal trajectory. This is changing brain chemistry of a baby in 10 weeks. And it's very cool. And the intervention, again, is through the parent. So the child is the outcome, but the intervention is with the parent and the child together. So that's one that we have going on now, which I'm excited to think about how we would spread that with all of you. And then the last one is this video feedback intervention, and it was actually developed by the folks from the Netherlands, which is very similar, but it's focusing more on preschool age kids. Again, we don't have that one here, but we do have ABC. ABC goes from 6 months up to 4 years, and it's out of the University of Delaware. They just developed a specific treatment for opioid addicted parents, and they start prenatally because, again, as you were talking about with babies who are born with NAS, they do not regulate and they cry all the time. So it teaches the caregiver how to keep holding that baby even though they won't stop crying before the baby's born. So we're excited to think about bringing that into the state as well. This one is yours.
Okay. So, and Ruby, before you go off on that one, I wanted to let you know there was a question in the chat that had to do with your last comments. It says, is the peer support specialist a new position and different from certified peer recovery specialists?
It's new for Minnesota, I would say, as far as certification, but we've had recovery coaches around for a while. And there are certified recovery coaches in other states. I know Illinois is one of them and a number of others. But the term recovery coaches, to make it billable for their services, the name changed to peer recovery specialists. And we've had that position around for a while too. But for us, especially in women's services, it became billable through our last substance use disorder reform plan that went through legislature.
The billability is based upon those who are certified, correct? It's not just the old recovery coaches, but you do need to go through the training and be certified by the Minnesota Certification Board.
Right.
Okay. Hope that helps. Let us know, Jean, if you want some further clarification. Go ahead.
Okay, thank you. With all of what has been shared with you this morning, we know to do all of this work, wonderful work and exciting work, as Catherine has mentioned, a lot of this takes systems working together. And a lot of the work that we've been doing in the past few years are all geared around systems interventions for families. And we are really excited that SAMHSA is now pushing more to do a lot of the systems work between child welfare and mental health and even corrections to try to bring all of these key systems together in looking at families, because as you know, a number of you know, that the set-aside dollars through SAMHSA was basically geared toward women that are experiencing substance use disorder. But now we are moving more toward the family-centered approach and bringing families more together, addressing their needs. Whether the woman is still the core client in the system that we are funding, but now SAMHSA is becoming more flexible as far as dealing with other family members, especially the fathers. So we have programs that are now pulling in the fathers, if nothing else, for visitation and dealing with overall parenting for the child. So some of those avenues are opening the doors to look at more of that whole family systems approach. So in the past few years, we've been doing trainings around trying to bring child welfare and substance abuse treatment professionals, mental health providers, corrections, all of those key systems that have some impact on the mother's health and getting her well and dealing with that substance use. And so if we can get more thinking on the same path and wavelength as far as how to best treat the mother and her families, this is one approach, cross-training, that has been very effective. we're looking at doing more of this. But through the summits that we have put on, we put on 2 so far, one in 2015 and another one in 2017. And it's amazing in connecting and working together at the local level of the things that have come about, and hopefully the plans that will be activated that can go to legislature to help them with more resources to serve the families. So that's one approach we've used, is cross training. And then the other aspect is the co-location of substance abuse specialists in child welfare offices. We haven't done much with this in Minnesota, but I know in other states it's been very effective by placing them in at the local level in a number of the child welfare offices that are out in the community, which is able to make it more accessible for mothers and their families to get the help that they need. And of course, this is an ongoing approach. The next one, cross-systems partnerships. We try to bring in as many of the key partners in helping us do the planning and dealing with policies around the best effective approaches and strategies, especially best practices. And one of our major partners is the Minnesota Department of Health. We work with them closely in putting on trainings and also sharing resources at the state and local level in the public health aspect. And another key partner has been the mental health area. And fortunately, we are now integrated at the state level, and we can work even more closely. And as Catherine mentioned earlier, there are some exciting things we're looking at coming up soon in partnering, sharing resources around the whole parenting area. That's a very core area of work for the providers that serve this target group, mothers and their families. And so with models that are coming forth now that can help improve the overall health of the children, this is what we've been looking for. And also can reduce the costs involved with serving the mother and her families. We have cross-system information. This has been effective quite a bit in sharing child welfare data with substance abuse data. We are working on how we can make it even more accessible, where we can tie into even bringing our mental health data with substance abuse data. So it's a whole lot of possibilities with technology. Hopefully we'll get there sooner than we thought before, but it's of great need when we can compare data with other systems and look at the total families. Joint planning and case management is always a necessity, and great if you can do it in providing that whole case management piece. We are exploring possibility of creating hubs in the state that can bring these key areas together, which would take lots of planning, and to have the key people at the table. One thing I've always pushed for is to have the voice of the consumer at the table as we're doing the planning. So in whatever way we can make that happen, that's the way we want to go. Case management might be one of the possible billing services we can look at that providers can utilize in billing for those services, where they can use grant dollars for another aspect of the overall programming. And you've heard a lot about wraparound services, I know, and we continue to see that as an important piece for providing these services, and as comprehensive as it can be as far as community service. The less we can have the client going from one place to the other, the better. They can have it there in that local area, whether it's a clinic or whatever program is necessary, the better for them. And so if we can create that type of setting, that's what we're looking for. And this is the type of strategy that works best for them. Financing strategies, a lot of possibilities. We're being a little more flexible on how dollars can be used in serving the mother and their families, and how we can bring sources of funding together to serve them. The one recent development was through the Title IV Families First Prevention Services, where our providers can tap into child welfare and utilize their resources and hopefully some additional funding to get at the effective programming for children, because that's one area. We can beef that area up and really make things happen more for the children that are coming in with the mothers in the programs. That's one way we want to go. And it's gradually looks like it's starting to happen. And again, like we say, the data systems, linking more of the key data system together is a plus for us at the state and for others out in the community and serving this clientele. So as technology improves and we work more with confidentiality requirements and so forth, I think this will happen sooner than later as well. So in that resource at the bottom, you can always look up the Child Welfare Information Gateway that shares a lot of the models that have been used in these different ways, the strategies that have been used, and can give you a lot more detailed information.
So we have about 2 minutes left before we should open it up for questions. So if you want to go ahead, this is our last slide. And we'll go through that and have some questions.
Okay, I won't go into each one individually, but overall you can see changes, at least different policies that have been worked with in improving the overall care for the mother with substance use disorders. Promotion of protective factors. We have had data collected by our research group Wilder for over 5-6 years, and can actually show the importance of promoting more of those protective factors. And we know that's a plus for prevention anyway. So the more we can promote that, the better. And then early identification of at-risk families is something we really hope can develop more. We do have our prevention people in our division at the state level, but the more we can work with identifying families early on, the better. So early intervention is very important for us to look at, making sure it takes place. And timely access to the substance abuse treatment. A lot of this is coming about through our SUD reform plan to deal with timely access. And this is what we're always looking for, the requirement of priority of where the mother's placed at the top of the list to get into the programs instead of waiting for months to get the help they need. So this is a very key area that we're working on and trying to improve to make it more accessible. And I'm always talking about gender-sensitive treatment and support. Gender-responsive treatment is a plus and must be if you're dealing with this high-risk group of women with substance use disorders. And I've talked about family-centered earlier. That's very much a need to continue pushing that. Recovery coaches and mentoring of parents. This is all a lot, the peer recovery specialist continues to carry that role, and we hope more of the mentoring can happen with the program. So the more we do these positive approaches, the better outcome for the mother. And again, the source is listed there if you want to find out more about these type of protective factors, prevention, early intervention. That's a good source to refer to.
Wonderful, thank you. So we're going to close out the PowerPoint, and I want to invite anyone who would like to ask a question to either type it into the chat or just unmute yourself and ask.
Can you hear me?
Yes, we can.
Okay, I had a question. It was going so fast, I can't see the PowerPoint. What is ABC again? What does that stand for?
Attachment biobehavioral catch-up.
Attachment.
Biobehavioral catch-up. And if you Google the attachment biobehavioral catch-up, you will get to their website for the University of Delaware. And actually,
Okay.
list of clinicians. It's a billable service for mental health. There's a list of clinicians who are certified in that intervention across the state.
Okay, thank you.
Yep.
I want to also suggest, you're from Fond du Lac, yes? The last question?
Yes.
Yes. Will you be sure to type in your name and your contact information in our chat? And then I'll be sure that you get the PowerPoint since you can't see them.
I can't get into the chat either. I've tried, so I was emailing Lucia Diaz.
Yep. Lucia will help us make sure.
Yeah, asking to send the PowerPoint to me if possible.
Absolutely. We'll send everything to you along with the survey. So thank you. That was the right thing to do. Any other?
Yeah, thank you.
You're welcome.
How do I unmute? Mute again. I mean,
I can do it. I did it for you. Okay, who else? Anyone else with a question? Well, just pipe in. I'm going to talk because dead air is just no fun. We're excited about this presentation, and we are very happy to get all of the supporting materials to you, and we'll do that within the next couple of days. Also remember that by completing the evaluation that you get in your email, the last question is checking whether you want the continuing education credit or not, and then your certificate will be emailed to you. We want to encourage you to invite colleagues to join us. As we heard, you just email Lucia, or you could email me, but you've all got Lucia's information. And just let us know either their name and email or have them do it themselves, and we'd be happy to add you to the contact list. It's easy to participate, and it's free. It's grant funded. Thank you, DHS and SAMHSA. And then if you have interest in a topic that we have not yet covered, or more in-depth coverage of a topic that we have covered, please send that information to us as well. All those echo sessions that we've been able to record are stored on our website at waysiderecovery.org under the professionals tab, and you'll see echo, and you just click on that and they're all archived there. So if you missed a topic or you want to see what we've covered, you certainly can go there and get that information, and we're always open for new content and suggestions. Finally, coming up, we have on the 5th of September, Randy Anderson, who is a peer recovery specialist and a number of other things, is going to be with us and talk about how we can all be a part of the advocacy movement and helping people with substance use disorder and their families see systemic changes through public policy advocacy. We're also then later in September looking at the Equal Footing program, which comes from to us from the Family Development Center. We have a safety and wellness in relationships topic that we're going to hear about, and the dynamics of coercion and control that sometimes are apparent in a substance use disorder relationship. And then in October, we're looking also at gratitude and addiction recovery. So we have a lot of really exciting topics coming up. We also, since you have signed in with us via Zoom, we're going to be offering our Wayside Friday Forum series via Zoom. You can either come in person, we'll have a small audience, or you can join us from your office or your home, wherever you'd like. Our first offering in September will be Understanding East African Clients with Co-Occurring Conditions. and focusing specifically on Somali clients. And then in October, HIPAA and CFR 42 in co-occurring treatment settings. Those will also be approved for 2 hours of continuing education. There is a small fee for that one. But if you want information, again, email us. We'll send you more information as soon as we have it all put together. Does anyone else have any other comments yet? I want to thank our guests for coming and sharing this information with us. And we'll get more information to all of you to support what we've heard today. Anything else? Thank you all so much for coming. I hope that we'll hear from you or see you again soon. And have a great day. It's a beautiful day in Minnesota. All right, thank you.
Very good.